It has also been included in the upcoming diagnostic criteria revisions, but in a much more limited way, just because it's at an earlier stage of development. But the field is really excited about these lesions, and you've probably heard about them, paramagnetic rim lesions, or PRLs. And in a nutshell, the reason we're so excited is because we know that there's different pathophysiologic processes that drive relapsing disease and progressive disease. And it turns out that having these chronic, active, smoldering lesions, I know people don't love that term anymore, but I still think it's a good term. Some lesions, form and then they become inactive, but some lesions have this rim of activated microglia, and they continue to have slow-burning chronic inflammation. And we know that these chronic active lesions are a major driver of progressive disease biology. And that's kind of the part of MS that we haven't really gotten a handle on. So that's why the field was excited about PEARLS, because we thought that it's an imaging measure that can actually detect these chronic active lesions. But what was kind of like a bonus and icing was that it turned out having a PEARL is actually really specific for MS as well, and this is why it's made it into the diagnostic criteria. So it's highly specific for MS in the range of around 95%, but unlike the central vein sign, it's not as sensitive, meaning that not everybody with MS has a PEARL, and it's about 50 to 60% of people when you look at studies. So in a nutshell, with central veins and PEARLs, they're very helpful but not essential for an MS diagnosis in the upcoming revisions. The central vein sign, because there's so much evidence, has been incorporated in all parts of the new diagnostic algorithms, whereas PEARLs have been incorporated only in a specific area, and this is only because it's at an earlier stage of development and there's not as much evidence. So these are what the diagnostic algorithms look like. Please don't be overwhelmed. You'll see the paper, but just wanted to highlight that CVS and PEARLs have made it into many parts of the diagnostic algorithm, and this is the diagnostic algorithm for people with RIS or who have atypical symptoms. Okay, so really quickly, how do we use MRI in addition to diagnosis? And I know I'm kind of short on time. As I said earlier, we use MRI as a disease monitoring tool as well, and this is because we recognize as clinicians that even though we take really good histories and we do the neurological exam dutifully, it's not good enough for monitoring all of the disease activity that's happening in MS, because MS, like many chronic neurological diseases, really fits with this iceberg analogy in that what you see on the clinical surface is but the tip of the iceberg of what is actually happening with respect to the disease. And so this is where MRI also plays an integral role. We actually know that MRI disease activity happens 10 to 20 times more frequently than clinicians can detect MS disease activity, which is why, particularly in relapsing MS, it's so important to regularly scan your patients. And this is because we're trying to prevent the dreaded brain atrophy, as well as, which is the strongest correlate of disability accumulation in the longer run. And there's quite a bit of evidence supporting why we use MRI regularly. And when I say MRI, I mean looking for new T2 lesions or gadolinium-enhancing lesions. And we do this because ultimately we want to reduce these clinical measures in MS or get rid of them altogether, which are relapses and disability progression. And this study was probably the most definitive study that illustrated why we need to do this. So this was a meta-analysis that included over 20 clinical trials, including over 20,000 patients with relapsing MS. And what Maria Piasarmani found was that when a treatment has an effect on decreasing new T2 lesions, it has a really strong effect on decreasing relapses with an R-squared value of 0.7, which is really, really high for clinical literature. And then similarly, when a treatment has an effect on decreasing new T2 lesions, it has a really strong correlation with the treatment's effect on decreasing disability progression. So this study really showed definitively why we need to use MRI to monitor people with MS, because very clearly when you decrease new lesions from forming, there's a very strong correlation with decreasing the clinical endpoints that we want to actually decrease or get rid of altogether. So there's many treatment guidelines around the world outlining how you should use MRI to monitor for MS disease activity. And I just am Canadian, so I put up the Canadian treatment optimization recommendations. But many recommendations are similar to this in that it states that when you're on a treatment and over a year you've developed 3 or more new lesions, this is the time when you absolutely should change treatment. But even if you develop 1 new lesion, it's enough for mild concern and you should consider changing treatment as well. This is the modified Rio score, which similarly illustrates that clinicians should be monitoring for relapses as well as numerous new MRI lesions developing when people are on treatment, and this should guide your treatment decision making. Okay, so what else is emerging in clinical practice? And I promise I'll finish in the next couple minutes. So we already talked about how pearls are a diagnostic tool because they're so specific for MS, but I already alluded to the fact that there's been excitement about pearls because we think they may be the imaging correlate of disability progression, meaning that we use new T2 lesions and GAD lesions as kind of the imaging correlate of relapses. And so the field has been looking for a long time for an MRI measure that we can use to monitor for disability progression. And so very clearly, a number of groups have shown that having more pearls very strongly correlates with having more motor or cognitive disability. And so the thinking was that maybe pearls can be used in either clinical trials or in clinical practice to monitor for disability progression. But it turns out it's not going to be that easy because in general, pearls don't change very much. So when someone has a pearl, it tends to stay there for a decade. And then a lot of pearls don't really form spontaneously, and a number of recent clinical trials have shown this. But where pearls might be used, and this is very recent data from the tolebrutinib phase 3 clinical trials, is that it very clearly is a really useful prognostic measure. Because in these clinical trials, when people had no pearls, the risk of disability progression over the trial duration, which was about 2 to 3 years, was way less than people who had 1 or more pearls. So this is a way we might be able to use pearls to actually, in clinical practice, know who might have more progressive disease biology and may progress more rapidly, and importantly, in clinical trials, to try to select for people who have a higher likelihood of progressing. So pearls are not ready for prime time use, but just wanted to plant the seed that eventually there may be a utility in clinical practice for disease monitoring. There's also fluid biomarkers, and I'm really shifting gears here, but kappa-free light chains have now made it into the new diagnostic criteria, and it's pretty easy with this one because essentially they can take the place of CSF-specific oligoclonal bands. And the reason they're useful is because kappa-free light chains are much easier to measure than oligoclonal bands. With oligoclonal bands, it's actually only done at specialized centers because you require some pretty advanced detection methods. And so it can be quite time-consuming and rater-dependent. But kappa-free light chains are also synthesized in people with MS in the central nervous system, in addition to immunoglobulins, and they're much easier to detect, and many routine labs can actually detect this. So this is a way that the diagnostic criteria have become more universal because at centers where you don't have access to oligoclonal bands, you can now use kappa-free light chains in lieu of oligoclonal bands. And this is just a slide showing that the diagnostic properties of kappa-free light chains are very similar to oligoclonal bands, which is why they can now be substituted. Finally, you've heard a lot about fluid biomarkers, including neurofilaments as well as GFAP. Neurofilament is just the most abundant one of the most abundant proteins on the axonal cytoskeleton. And there was a lot of excitement about this because initially NFL could only be measured in the cerebrospinal fluid, but then we now have these ultra-sensitive techniques where you can measure it in blood. And so people thought maybe this is a blood test that will help us monitor progression in MS. But what's interesting is that NFL, it was thought that it could be a measure of progression, but it turns out it's very, very sensitive to any relapsing disease activity. So strongly correlated with relapses as well as new T2 lesions or gadolinium enhancing lesions and over time disability. And so it's possible that in the future, if you have access to NFL, this may also be a measure that you use in clinical practice to monitor for relapsing disease activity as well as possibly to prognosticate. And then just wanted to plant this seed. There are some very recent studies showing that if you actually control relapsing disease activity, as was done in the ocrelizumab clinical trials that are shown here. So once people are on ocrelizumab for a full year, if you then measure NFL, it turns out at that point, when you've kind of abrogated all relapsing disease activity, NFL can be a really useful measure that's strongly correlated with disability progression. So if you think about things like timing and then maybe even combinations, GFAP, which is this astrocyte protein, is now emerging as a useful measure that may reflect progression as well. And when you have low NFL and high GFAP, it turns out that people have a very high likelihood of progression. So if we use some of these fluid biomarkers in a smart way, together with imaging measures, it may be that we will be able to better monitor progression in clinical practice in the future. Okay, so I know it was a lot of information, but I hope I've been able to summarize how we use MRI clinically for diagnosis. Some of the key changes to the upcoming revisions to the diagnostic criteria, where for the first time we're incorporating highly specific imaging measures, including the central vein sign and paramagnetic rim lesions. We also use MRI regularly in clinical practice to monitor for disease activity. And then there's a whole bunch of emerging imaging and fluid biomarkers that hopefully will allow us to, in the future, better monitor for disease progression, which is one of the big unmet needs that we have in clinical practice. So thank you for your attention, and I look forward to discussing more.
Thanks, Dr. Morrow and Dr. O for some amazing presentations. Quick but amazing. So we have some questions that have come in. I would encourage you to scan the QR code here, the same one that you used for your pretest. And what we're going to do is we're going to, in the interest of time, I have one question that I'd like each of you to address, and that is, many of us as advanced practice providers are not just in academic centers, but out in community centers, some large, some small MS centers. If you had to pick one of the biomarkers that's either currently used or emerging that you would predict might be the most helpful to us in our practice, what would that be? And a quick response.
Sure. So for me, and I think in my clinical practice, when someone is sent for an MS diagnosis, one of the things I look for is spinal cord lesions, because you can see nonspecific white matter lesions in the brain, but as we talked about before, even in the posterior fossa, you can sometimes get lesions that are there but are not necessarily typical for MS. So for me, someone, if I'm seeing, because I do all the reviewing for the triaging, so anyone who comes in with a spinal cord lesion, for me is like, oh, this is very suspicious of a true MS diagnosis. So I usually prioritize them higher. So, and it's simple to get right now, so that's the one I like the most currently.
I'm biased, Amy, and I'm going to go with the central vein sign. But you know, just so that everybody's aware, there will be MRI papers published that will have very clear sequence parameters so that even smaller community centers can use this sign. And it's very easy to detect, and it's just so useful, as you saw. And so I do think it will be something that will be taken up pretty readily and really useful in clinical practice.
Great. Thank you so much for your presentation. We're going to move on now to our next two speakers, Dr. Scott Newsom, who is a professor of neurology and the director of the Johns Hopkins Stiff Person Syndrome Center of Excellence, among his other accolades, as you can see, and a fellow board member for the CMSC. And Lisa Fox. Lisa is a senior physician assistant and the assistant director at the Johns Hopkins Neuroscience Center, Johns Hopkins University. So we'll start off with Dr. Newsom. Thanks.
Okay, well, thank you so much. When Amy had reached out to me about being involved in this program, I said, absolutely, this is a great initiative. And a couple words after that made me even more excited. She said, I also in parallel reached out to Lisa Fox, who's the PA, my right-hand colleague at Hopkins, and then told me about the rest of the esteemed faculty. And of course, there's always a negative, a bad, that comes with so many positives, and it was this topic. So now we have over 20 approved therapies. And so there's no way I'm going to be able to do justice for each of the therapeutics and the amount of time we have. And just to forewarn you, all the information you're going to see at lightning speed is like 4 presentations together. So just take that in consideration. So get on the Newsom and Fox bullet train, right, as I like to say. Okay, this is an overview of our presentation. We're going to tag team. You already heard plenty about the importance of diagnosis, and I'll just touch on that with respect to, treatment considerations. Then I'm going to do a very high-level view on the pivotal trials with all of the therapies that have been approved for use, and just again focus on high points related to the efficacy. And I think to be fair and balanced, it's always important to look at the safety profiles of the therapeutics that we're using. But again, we're going to do a really high level there and touch on a couple things that maybe some of the audience is not aware of with some of the therapeutics that we use. Lisa's going to spearhead recently approved and emerging therapies of interest, and then we're going to tag team the rest. Okay, why do we care about treating our patients? Well, you heard, I think, plenty of information with the prior talks, but I just want to remind people, before we had therapies, before 1993, the natural history studies related to MS showed that the majority of people actually accrued disability. And some of these people actually within the first few to several years needed an assist device, i.e. walker and beyond. And so, I just point your attention to these studies because it's a nice reminder of where we were and how far we've come. And in fact, many of my clinics, we do not see people in wheelchairs and walkers. There still obviously are some people that did not have the availability of some of the therapies I'm going to go through back in the day, but we're doing a lot better. And this last bullet point, I do point your attention to this study. You should have all these slides and all the different references, because I thought this was very instrumental, at least in my reading and education, as this is a study that had quite a few people that were followed over 3 decades, and at 10 years from the initial follow-up time, the patients were deemed as having benign MS because they could walk, basically, right? And then subsequently over the next 2 decades, none of them actually were now deemed as having benign MS. So MS is a bad disease. We need to treat it. So once the diagnosis is made, I think it's very important, at least in my view, to determine is there activity or not. And activity, what I mean by that is, are they having relapses and new MRI activity? We know from many, many studies, including pivotal trials, that those that have a certain level of activity will do the best with our current therapies. Not to say that some of our progressive patients don't deserve treatments, but we just have to be careful with exposing some of our patients to therapeutics that could get them into trouble. So be mindful of that. And then when you're in clinic with patients, I think setting expectations for them. Right? I remember when one particular therapeutic was FDA approved and they were showing commercials or a CNN spot of a patient getting out of a wheelchair, our phones rang off the hook. And I'm sure some of your centers and private practices and other did the same. And, I want this medication because this is going to improve my function. I'm going to get back my life. So we really need to be honest and transparent with our patients and, tell them what we know and what we don't know. And some of the exciting work that you saw earlier, presentations, will give them, I think, hope for the future. So earlier diagnosis, get them on treatment, less disability. All right, get ready. So this slide is very crowded. And as you can see, some of the bubbles, I think from here, the drugs are trying to bust out of those bubbles because they're jealous. But if we go back to 1993, first FDA-approved therapy, interferon, all the way to last year, late last year, a new formulation of ocrelizumab, over 20 therapies available. It's very difficult, though, when you're seeing a person in clinic, whether they're newly diagnosed, treatment naive, or someone who's failed 1 or 2 therapies, like what do you do with the information you have? So, what I like to do is think about these bubbles. I'm saying bubbles a lot, but think about the bubbles where you have increasing efficacy and what's the increase in burden of treatment, which is not necessarily side effects, right? The increase in burden of treatment could be labs. Some of our therapies that we recommend for patients are very lab heavy. Others, maybe not lab heavy, but they have other issues associated with it. So think about the yin and yang of the different treatments as I go through the trial data. So I wanted to put this up front because once we talk about mechanism of action, most people, their eyes glaze over like, my gosh, another immunology talk. No, this is just really 50,000-foot view. I think it is important to have at least a basic understanding of the MOA of certain drugs, because that can actually help you understand what potential complications can ensue from that. So in these buckets, immunomodulation, I would say we put these therapies in, although I would say the fumarates we learned after unleashed to the great world and many people using it, that some people actually get lymphopenic, that is actually apoptosis occurring, and some patients unfortunately got PML as a result of that. So just because there's a drug that their main MOA is immunomodulation does not mean that they don't have immunosuppressing effects. But I think most of you are familiar with sclerotermer acetate, self-administered injectable, the interferons as well, and then the oral fumarates. So what about the cell trafficking drugs? I think Lisa is going to touch on this later, but again, mechanism of action for the cell trafficking drugs, very important. We learned, unfortunately, that with stopping the cell trafficking drugs and waiting too long, some patients can have rebound attacks, right? Rebound attacks where those attacks are much worse than the patient ever had beforehand. So this becomes important when you're thinking about, okay, maybe someone can't be on natalizumab forever because their JCV, went up over 2 antibody test, and you need to switch them off, or the S1P modulators, for whatever the reason you want to switch off of them. So there are strategies that one can take to try to minimize the rebound attacks that could occur. I'll just talk about teriflunomide. So the mechanism of action here, it doesn't destroy cells, it causes cytostatic proliferation. So it prevents those angry activated B and T cells from proliferating more. And then, of course, we have the more selective depleters, as you can see listed here, which have gained a lot of attention, obviously, because of how well they work. Not to take away all the other drugs that are on this slide either, because at the individual level, any of these drugs could work 100%, right? So, take that in consideration when you're seeing a patient. The best medicine, the best medicine for the patient is what? The one they'll take. And I'll tell a story in a little while about that. Okay, so this is the injectable DMTs, the older generation injectables, as I would refer to it. These are the trials that were versus placebo. So you'll see some of these numbers that we always quote, or we used to quote, in clinics that would use interferon therapies and glutamate acetate. Now, violating a very important rule, and that's comparing trials across decades, different diseases that you could say within the populations being studied. But this is really a good way to, I think, look at it, at least for broad strokes. So, you'll hear us say, decrease relapses with these therapies by about 1/3, maybe some a little bit less. Then we talk about MRI activity. You can see the numbers there. And I just want to point your attention to the decrease in Gad-Hansen lesions for some of the therapies. So into the 80 percentile, right? We get excited about Gad-enhancing lesion suppression above 80%, and some of the older therapies actually did do that, right? Now, this is against placebo, right, these numbers. So some of the newer trials are against active comparator and not placebo. And then this EDSS, which you heard about earlier, which is a way we can measure progression, about 1/3 of the patients in most of those studies presented there. Fair and balanced side effects. We can't go through all of these, but I just want to point out a few things that may be important in your consideration about starting a therapy. So interferons, there and I learned this when I was a fellow, that interferons can actually unmask or provoke rheumatological conditions. So if you have someone that is rheumatologic or has rheumatism, not a good class of medications to start. And so keep that in consideration. Also, I've seen a couple cases of autoimmune hepatitis actually with interferons. So it can unmask autoimmune hepatitis. It can happen any time. It could start within the first 6 months of therapy or many years down the road. Hence why the monitoring, at least in my view, is to continue monitoring at least CBC with DIF and LFTs, not just for interferon, but really all the treatments that we're going to be talking about. I think most of the time, if someone's failing an interferon therapy, truly failing, they're taking it, they're adherent, they're having disease breakthrough, at least where I am in the neck of the woods, we're not doing neutralizing antibodies anymore. We're just going to a different class of medications. Other parts of the world, though, may still be utilizing this because their access to certain drugs is not as robust. And then, of course, scleroderma acetate. I think most of you, well, let me see, raise of hand. Lipoatrophy. How many of you actually have had patients with that? It's not insignificant. So, do skin exams on your patients. It's a little uncomfortable, sometimes, but I think it's very important to do. Skin necrosis, I've seen in a handful of patients as well. And now there's this new black box warning, right, that's out there, which it's not new, but it's new. I don't know. So anaphylaxis can happen, really, with any drug. I think why this gained attention is that there were more cases being reported, and there's no time limit for this, right? Again, a lot of medications, the side effects, we tell people, to get better over time. However, with anaphylaxis, that's not the case with scleroderma acetate. I used to think that there was no specific labs needing monitoring, but I would encourage people at least yearly doing basic labs. There have been a couple case reports out there with liver dysfunction associated with scleroderma acetate. Albeit rare, maybe it's confounded by other medications, but still a good rule of thumb. Okay, moving on to oral DMT efficacies. Now, I'm sort of a lumper with some of these things, so bear with me. Fingolimod, I end up thinking about the S1P modulators together, but I'll make some caveats with that. So here you'll see from the pivotal trials against placebo, fingolimod, teriflunomide, high dose, dimethyl fumarate, around 50% for fingolimod and dimethyl fumarate, again against placebo, into the 30 percentile for teriflunomide. You see MRI activity across the board, decent in the 80 percentile with GAD-enhancing lesions, T2 lesion, decreased burden you can see there, and then a third disability progression. Now, the measures we use clinically for disability progression, this EDSS, some would argue 12 weeks is not enough. So you'll see now some of the clinical trials are actually looking at 24-week confirmed disability progression. And I'm sure some of you, if not all of you, have seen someone come in with a bad spinal cord attack, bad brainstem attack, and it takes them 6 months to recover, and sometimes even longer. So that's where the 12-week disability progression, it's nice to see, but I'm a bigger believer in 24-week data. So very quickly, again, bullet train, right? Second generation S1P modulators, you may ask yourself, well, why? If fingolimod worked very well, why would you want second generation therapies? So the challenge was that fingolimod is non-biased in terms of its targeting of these S1P receptors. And in the clinical trial profile, there are people having cardiac events. Now, folks looked back and really looked at this and did a lot of, I think, good studies. It's rare, but it can happen. So the more selective second generation modulators that were developed were an attempt to try to mitigate some of those more common side effects. And so here you can see the three other players. Siponimod, as many of you may know, there was a phase 3 clinical trial program that looked at secondary progressive MS. They did not look at relapse and remitting MS. There was a phase 2 trial that did. And here, this is the trial results that led to the FDA approval of siponimod for SPMS. And so I think this is an important move forward for the field because now, if you think about the therapies we have available, if we put aside PPMS, they all really have this blanket coverage for relapsing forms of MS, which include whatever active SPMS means. That's a whole separate discussion. CIS as well for most. Ponesimod and ozanimod, you can see the data here from the relapsing MS studies, but this was against active comparator teriflunomide. And when you look at the numbers, again, active comparator data, so important, met the primary endpoint with analyzed relapse rate, secondary endpoints, many, and then there was non-significant difference in confirmed disability progression. And you'll hear this actually with some of the active comparator studies of late versus teriflunomide. I don't know why. Maybe teriflunomide is a better drug than we thought. Maybe it works on progression better than we thought. I have no idea. Anyways, there's a place for all these medications, I believe. So diroximol fumarate, many of you are probably aware of this. You can see the chemical structure to the right. It's a little bit different than dimethyl fumarate on the left. The reason there was an appetite to make a dimethyl fumarate-like medication, or I don't want to say 2.0, but I will, I'll get in trouble, is because a lot of people were discontinuing dimethyl fumarate secondary to GI symptoms. And people were only taking it for a couple weeks and then stopping the medication, which obviously that's not helpful. So diroximol fumarate was shown in a non-inferiority study to be equivalent in terms of disease activity suppression to dimethyl fumarate, but better tolerated based on the chemical structure, as you can see there. Now, there are some anecdotal observations that there's a higher prevalence of lymphopenia that happens with diroximol fumarate than dimethyl fumarate. That's my own personal, my clinic. Maybe others have the same opinion, but nonetheless, it's still something to look out for, and we'll get to that in a second. So fingolimod, S1P modulators, lymphopenia occurs. This is where the mechanism of action is important to take in consideration. Those activated lymphocytes are sequestered within the secondary lymph organs. They're not allowed out. And so that's why when you take your blood, you see the ALC being low. Please check CBC with diff. The diff part is what gets you the ALC. You can see that also transaminitis can occur, so check your LFTs. The major side effects, as I alluded to, some cardiac events, infections really can happen, I would say, with all the drugs we're going to be talking moving forward. The therapies that I would say arguably target the immune system in a stronger way have an infection tag associated with them. And infections could be shingles, could be herpes, meningitis. There's a lot of different ones. So be on the lookout for anything that's different in your patient. Macular edema, melanoma for S1P modulators. So monitoring, you can see there's a bunch of different things. The one thing I'll mention is the second generation S1P modulators, including ozanimod, specifically, is there's no first dose cardiac monitoring. So talking about hassle factor or lessening the hassle factor for patients, that's nice. Teriflunomide, when I present this medication to my patients, they're not enthusiastic about some of the minor side effects. We try to walk them through it. We try to relay to them that this is, if it happens, it's temporary, and studies have shown that to be temporary. Major side effects, which I don't know if we can say for sure pregnancy concerns, and because we can do a washout if someone does get pregnant or if someone's on the drug, you can do this active washout that gets rid of the drug. I've seen peripheral neuropathy occur with teriflunomide, which is very tricky, right? Because you have our patients that have numbness and tingling. They come in, they have increased numbness and tingling, violates the 24-hour rule, and you're like, well, is this a relapse? You do imaging, including their spine imaging. Maybe it's a small lesion, I don't know. So think about EMG, nerve conduction studies, if you come across that, with all other exam findings being stable in someone on teriflunomide. Hypertension, I've seen a few of those, so make sure you pay attention to that. And there are some serious skin reactions. I have not seen this, but you can see the list there. And what I neglected to mention, look at the prescribing information of all these drugs every so often. That's where you're going to get most up-to-date side effect profiles, even rare one-off events. It's mandated by the different governing bodies for medication safety. You probably know the monitoring for teriflunomide and many other medications we'll talk about, checking, making sure someone doesn't have active, TB or hepatitis, and dimethylfumarate. Sorry, no, I'm rapid fire here. But dimethylfumarate, fluxion, GI distress, you know about that. PML, I already alluded to with the lymphopenia. There have been a couple other really, fortunately rare, but significant infections, Listeria rhomboencephalitis. That was a report that's out there. Herpes encephalitis. So, monitor patients. And I will say most of these really severe side effects, at least for the fumarates, seem to be linked to the lymphopenia. And that lymphopenia does not go away until you stop the drug. And so my usual recommendations is if I see someone, they have lymphopenia, which my definition is below 800 on the ALC or 0.8, we will test it monthly for a couple months, few months, and if it stays that low and it continues to go low, that means that apoptotic process is continuing, so you better stop the drug. And older patients who have had chronic lymphopenia, it can take a year for that to start creeping back up. So it makes it a little bit tricky for switching therapy. When do you start them on the next drug? So cladribine, this is, who knows LL Cool J? Right? Mama said knock you out, yeah? I got to stop making these references because talk about old, 50, it's not old. But I've been here for years, right? You know the saying, right? Cladribine's been around forever. Anyways, this is an oral option given infrequently over a couple years, targets the adaptive immune system. It was shown against placebo, and the data shown here, to be successful in preventing relapses, time to progression, MRI lesion activity, including this cumulative lesions, which is a combination of T1, T2 lesions. There were some concerns, actually, which held it up from getting approved by one phase 3 trial in the mid-2000s, and that was concern for cancer malignancy. But, I think there have been subsequent studies, follow-on studies, that have shown that maybe that concern is not as scary. But there are still a lot of other potential side effects, as you can see listed there again, infections, reactivation of certain infections, just like what we've talked about with other drugs. So what about the DMT efficacy with our current intravenously administered therapies? So natalizumab versus placebo, you can see the numbers there. So almost 70% reduction in relapse rate, GAD-enhancing lesions suppression over 90%, and then EDSS into the 40 percentile. So CARE-MS1, CARE-MS2, this is alemtuzumab against active comparators, so not placebo. So again, look at the numbers based on that. So close to 50% reduction in favor of alemtuzumab versus interferon beta-1a high dose. And then, the numbers there are a little bit tricky with the MRI activity, but it was in favor of alemtuzumab. And the 12-week disability progression, why would one study non-significant and the other really robustly significant? It's the devil's in the details. Look at the trial population within the clinical trials. That gives you an idea of who is being studied. And really, when you're thinking about starting a therapy, think about the trial population. So if you're outside those trial windows, it doesn't mean you shouldn't consider starting a therapy or escalating a therapy. It's just you have to be mindful of what we know and what we don't know about, someone who's older and has MS or a young pediatric onset. So ocrelizumab versus interferon beta-1a in the OPERA-1 and 2 trials. Again, active comparator, almost 50% reduction in relapses. You can see GAD and T2 lesion suppression in favor of ocrelizumab. And then there was this pooled analysis for disability progression into the 40 percentile. We're almost there to Lisa, I think, yeah. So ultimate 1, ultimate 2 is ublituximab, another IV, versus teriflunomide. over 50% and just under 50% relapse reduction in favor of ublituximab. You can see the MRI data in favor of ublituximab, including gout-enhancing lesions in the 90 percentile. And then the current confirmed disability progression, this was pooled together. That's why the numbers look the same. But this was not significant when compared to teriflunomide. So just to say, oratorio, ocrelizumab versus placebo, it showed that it was effective, at least I would say short term, and that's where this medication became FDA approved for PPMS. So this is a lot, right? It gets worse and worse as we go on with the number of potential side effects. But just a few things. So if you think about the IV therapies across the board, infusion reactions occur. They occur for most people up front. For some of these therapies, they get better over time. There's a wearing off phenomenon that many of us have seen. How many of your patients have referred to this as the crap gap? A lot of people, right? I thought this was a joke when I first heard this, and then I went on social media, which I'm not on social media a lot, and I saw this all over the place. I was like, well, there must be something to it, right? Social media says it's real. And then, the more people I saw, this is a true phenomenon. We don't understand it, but it does happen. Major side effects, just think about infections across the board with all these therapies. Some of the unique things for each of these therapies, just briefly. So natalizumab is another therapy that has been associated with unmasking of autoimmune hepatitis. In fact, I had a patient that almost died of fulminant liver failure because of this. And when you have a patient that occurs, it makes you a little gun-shy with therapies. Nonetheless, of course, the IV therapies are great medications, but be aware of that. Check your LFTs, check your CBC with diffs, obviously JCV antibody monitoring for natalizumab. Please do not use the JCV antibody serum test to determine whether you're going to use other therapies. I know people do it. I have colleagues that do it. The studies that are out there where we can risk stratify whether someone's high titer, low titer, or negative is really in natalizumab. So please do not use that for every other drug. You're going to run out of drugs. Most people end up becoming, if they're not already, JCV antibody positive, then you're taking out most of the armamentarium that you may use. Alemtuzumab, secondary autoimmunity can occur. We've seen vascular events occur as well. Immune colitis, there's been reports of that as well. Monitoring-wise, the last infusion, you still have to continue to monitor labs, monthly labs, up to 48 months. So this could be a deal breaker for some patients. Ocrelizumab, I think many of you have seen the cases that have come out with immune colitis, pyoderma gangrenosum, babesiosis if you live in the Northeast. So these are rare, fortunately, I think, with a lot of these major side effects, but be aware of them. Ask your patients about infections. What's their skin look like? Ublituximab, I would say very similar. And again, lumping all these together may not be fair, but in the clinical trial program, there was an encephalitis case, salpingitis, but again, these are infections. Ofatumumab, fully human monoclonal antibody. This is why we do not give steroid premedication versus some of the other therapies we use because they're not fully human, like ocrelizumab is an example, ublituximab. This is given monthly. You don't have to go to an infusion center, so some people like that. The B-cell depletion is quite quick. I would argue the other B-cell depleters similarly. There's some data showing that the repletion, so the opposite, may be a bit quicker, and hence why it's given monthly. Clinical trial data, I just point you to Asclepios 1 and 2, which is ofatumumab versus teriflunomide. You can see the numbers there in ofatumumab's favor. So there was a recent study, this is like within the week, I believe, that said MS patients have maybe a little bit increased risk of malignancy. And this has been a debate for many, many years. This was a nice study several years ago looking at least at that point in time, all the phase 3 trial data and the prevalence of malignancy in those studies. And what was seen is with all these overlapping bars, there didn't seem to be really one particular therapeutic class that jumped ahead for increasing malignancy rates. Now, this is aggregate data, so be careful. Okay. You're on.
Talk fast. Okay, so we're going to be talking about kind of emerging therapies here. And some of these you've heard about, and we're going to kind of breach off of a little bit of the B-cell depleting therapies so far. So we're going to start off with, first of all, thank you for having me. This faculty up here is quite impressive, and I really appreciate being asked to join them. So we're going to be talking about kind of ocrelizumab subcutaneous clinical development program. And we can see here in the OCARINA 1, it's a phase 1b dose finding study. And we studied some, they studied some dose escalation and saw that the most appropriate dose selected was a 920 milligram dose. And then it went into the OCARINA 2 phase 3 PK non-inferiority study. And they looked at the patients on ocrelizumab subcutaneous, 920 milligrams, versus ocrelizumab intravenous, 600 milligrams. And they wanted to evaluate that in the study, and we'll talk about that in the next slide. But here's the methods of the OCARINA 2 study design. You can see that up until the 12-week mark, they have 920 milligrams of the OCARINA subcutaneous, and they looked at also ocrelizumab IV, 600 milligrams divided into 2 doses, which most of you are all familiar with in that regard. At the 12-week mark, they then put everybody onto the subcutaneous dosing from dose 2 to dose 5. And through this study design, they then looked at the endpoints at the 12 weeks, but then they did assessments throughout, and you can see them through all the imaging and the little icons on the bottom there. From here, what we then looked at is the baseline patient demographics. And what was cool about this is it's very similar to the ocrelizumab intravenous dosing that demographics that we've seen to date that Dr. Newsom quickly reviewed a little bit. But what I always find cool about this is that looking at the MS subtypes, we see that there's approximately, it's hard when I can't see close, but I can see far. 90% in relapsing MS, and then we have about 10% in the primary progressive MS, and then we have active secondary progressive, a small subset in this population. But I also find cool is I always ask, what were they on before the studies started? And in this study, you can see that the variables included patients with prior DMT exposure of greater than 4%, were mostly the interferon beta-1As and the as well as glatiramer acetate and teriflunomide. And I'll revisit this in a verbal conversation with a few slides down, but you can see that's what they were compared to, that's what they had previously been on as we go through this data. And now looking at the PK value here, at week 12, we look at what is the administration of the doses to find the non-inferiority of the ocrelizumab subcutaneous formulation. And so we can see under the curve here is that what we've chose is that there was that the study of the ocrelizumab subcutaneous dose was very similar to the ocrelizumab intravenous 600 milligrams, so that the demonstrated PK non-inferiority of the dose formulations to be able to be moved forward. So why is this important in this respect? What are we looking for with this OCARINA 2 study of the subcutaneous dosing? And what we're looking at here is we're seeing that the OCARINA 2 study shows that we do have continued B-cell depletion. So not only do we have this continued sustained B-cell depletion, but it's quite active. And when Dr. Newsom showed the last few slides for the ofatumumab and the ocrelizumab, you could see that it was a quick onset of B-cell depletion, and it was quite quick and sustained. And this was very similar between the subcutaneous and the intravenous routes. Now, it's cool because we've heard Dr. Morrow's story, we've heard Dr. O's study, and Dr. Newsom's study, presentations, excuse me, not studies. Well, some of yours are studies, actually. That we see that there's such a critical thing. We look at all the clinical strides, and we've seen annualized reduction rate, right? Then we've looked at EDSS. Then we've looked at confirmed disability. Now let's take it to the next step with what you're about to see in coming slides with a different drug class altogether. And let's look at the pearls that Dr. O talked about. So in the Ocarina study with the ocrelizumab, you can see that 97% of patients were free of relapses at week 72. And their EDSS was stable up to week 72. Okay? We're moving forward with all these markers, the biomarkers of the MRI, and we're looking at them and we're seeing quite significant reduction in some of these studies. And then if we look at the MRI on here, looking at the T1 gadolinium lesion rates, they're 0.00 and 0.01. And the difference between those two are the patients that were in the Ocarina 2 study that went from IV to subcutaneous, and were in subcutaneous and subcutaneous. And we also see significant findings in the newly emerging T2 lesions, which also were maintained at week 48. So this is kind of very similar data to what you've seen from the ocrelizumab intravenous studies, but the new fun thing about all this is, what are these injections? What is this little butterfly in the tummy looking at as we do a 10-minute push? What is that? That's different. That's new for us. We've never had anything like this from a push standpoint. And you can see that there's two different we've broken them down into localized injection reactions and systemic. So localized injection reactions, there's some redness, there's some pain, some swelling, 40% down to 20 and 10%. And the systemic, not unexpected, headaches, some flushing, and some nausea, but under 5%. And all these localized injection reactions in terms of the localized ones were grade 1 to 2 severity. And they lasted, as you can see here, for maybe 2 days median, and the symptoms lasted between 1 to 3 days. And then what's cool about it, the further they're getting along on the injections, right, or subcutaneous route, you can see that from the injection 1 to injection 5, there's 60 milliliters of redness down to 45 milliliters. And after the swelling goes from about 100 millimeters to 80 millimeters. So there is a reduction in that, as just like you might see in ocrelizumab intravenous, that people might get less reactions as they go through. In terms of the systemic injection reactions, you can see that grade 1, 2 severity, and the symptoms were very fleeting in terms of about 24 hours on average. Now, in terms of infections, you can see that patients on the ocrelizumab subcutaneous doses did have some infections, but there was no skin reactions that were quite notable. And the largest infection that they did see in a grade 3 level was COVID-19. But most of the majority of the infections that were noted were very similar to the intravenous route of upper respiratory, COVID-19, UTIs, and nasopharyngitis. So now let's take this, and this data is just freshly reported as of this year by Dr. Newsom. And this is the PRO, so the patient-reported outcomes for the most part. And what we see here is that patients that were MS treatment preferences at week 48, okay? So we see that 82% of patients that were previously on a DMT, remember I mentioned all those DMTs of 4%ers that had more, had been on a disease modifier before they started Ocarina, then you could see here, not Ocarina, Ocrevus subcutaneous, my apologies. So you could see here that 82% of patients prefer the subcutaneous route comparatively to any of the other DMTs they had previously been on. And that 98 of them were quite satisfied, that's a pretty large number, or very satisfied with the ocrelizumab subcutaneous route as a treatment for their MS symptoms. Now, when we look at patient preference at 48 weeks, anybody that had an administration method preferred, 80% of the patients who experienced both the intravenous route and the subcutaneous route, actually 80% of them preferred the subcutaneous route. So a lot of our patients are like, why do I switch? What's going on with this? Why? It's a new kind of therapy. What's this 10-minute push into my belly, right? Well, you're like, well, it's a different administration method. And 80% of the patients in this patient-reported outcomes actually preferred the subcutaneous over the intravenous. So you can see here, here's a belly of one of Dr. Newsom's patients, where you can see the administration of the needle into the tummy. And post-injection 1 hour, there's a little bit of erythema, Post 3 hours, you don't see as much, but at post 12 hours, you can see that it's spread just a little bit. But again, we have not seen any major reported in skin infections in this respect. But these are some of the localized injection reactions that are most commonly reported. So, switching altogether, completely new, and you'll hear a lot about this year, are BTK inhibitors. And as I said, I'll be pulling in some terminology from everybody else's presentation so far. So Bruton's tyrosine kinase inhibitors, there's quite a few that's started in conversation over the past couple of years. And now all of a sudden we have a collective of quite a few all at once. It's not like a smattering here. It's like, boom, here they are. And so it's kind of cool because we're talking about these pearls, right? And this, I'm not a fan of smoldering, but that's okay. I like to call it chronic insidious inflammation because I think that sounds cool. But these different lesions where they're in the middle of our lesions, we do have this continuous kind of inflammation that we really haven't been able to identify, even though it's gone back all the way to Charcot, did I say that right? Charcot, back in the day, where he's identified kind of this lingering presentation. But we do have these pearls now, which I'll bring up in a couple slides, that are, if you have them, maybe this disability, earlier onset, with some of these disease processes are showing that patients can improve from a disability standpoint. So how do Bruton's tyrosine kinase inhibitors kind of differ, okay? These guys not only work on just the innate or the adaptive, they work on kind of a combination of the innate and the adaptive immune system. And if you've never heard those words, there's a presentation on Thursday morning about immunology that's kind of cool. Okay, I gotta keep going. Okay, so BTKs are cytoplasmic enzymes that mediate the B cell signaling via different cellular surface molecules, including the B cell receptor. And then what this does is BTK inhibitor then blocks the B cell proliferation so that it doesn't continue in that respect. Not only do they do that, they also affect the innate immune response through working through inhibitions of the macrophages and other cytokine release. And as you can see here, there's different medications listed, the tolebrutinib and the fenebrutinib. But we're going to quickly start off with quite a quick slide of 5 of the BTK inhibitors. And you can see that there's some differences, subtle for some, obvious for others, like the binding for one of them has a reversible non-covalent, where the other ones are irreversible covalent. And you can see that the CSF exposure in 3 of the 4, and 1 is still being in data to be published. Here are some of the ongoing clinical trials of the BTK inhibitors in MS. This is where we are. In the green, we are here. And you can quickly look at this to see what is coming, where we are in the state of our BTK inhibitor. And as I said, it's a big boom going on right now. Okay, evobrutinib, quick review. Okay, phase 3 trials, evolution 1 and 2. You can see here that there are clinical trials for relapsing MS. Evobrutinib was compared against teriflunomide. And what we see here is that there's no difference in the primary and key secondary endpoints, okay? And no difference in the confirmed disability improvement or neurofilament light levels either noted in this clinical trial. What we have seen from a safety standpoint is that there were some serious incident rates of the AEs of evobrutinib versus teriflunomide, about 7.5 to 5.6. And the biggest light that came out of this is that the liver enzymes kind of were like a little red flag. And we saw that the liver enzyme elevations were greater than 5 of the upper normal limits, more commonly reported in evobrutinib versus teriflunomide within the first 12 weeks. And this gave a little pause, and then we said, okay. And then we also saw that there's high cases in 3 of the evobrutinib and 1 in the teriflunomide. And once they stopped the medication, the patients did well, and they recovered their LFTs. Moving on to tolebrutinib, it's cool because not only do we have relapsing remitting MS in the Gemini 1 and 2 studies of tolebrutinib versus teriflunomide, but we also see Hercules study for non-relapsing secondary progressive MS. So that is, we're starting to use McDonald criteria that we've learned about earlier, and we're starting to do studies specifically more catered towards that. And we have the study of tolebrutinib versus placebo in this, and you can look up these studies quite easily for the, just how the studies were randomized in that respect. In the Hercules study, which was against placebo and the non-relapsing secondary progressive MS, you can see time to onset 6-month continued disease progression, and at the 3-month was statistically significant in that respect. The impact of tolebrutinib on the MRI endpoints, you can see that the newly enlarging T2 lesions were notably reduced. And then Gemini 1 and 2, the tolebrutinib versus teriflunomide, which was a relapsing remitting MS, there's no difference in the primary and key secondary endpoints, but the tolebrutinib safety of all the trials were very similar in terms of minor bleeding events, some respiratory infections, some transaminitis in the ALTs, and some bilirubins. Out of this study, there was, of all the tolebrutinib studies, there was one unfortunate death of an individual that had liver failure and then had a liver transplant and did pass from that. And with this is what's made us say, hey, we need to check LFTs. Okay, so that Hercules study has now changed the course of how we're now monitoring for any of the BTKs. So here, Dr. O did talk about the pearls, the paramagnetic rim lesions, as prognostic predictive biomarkers. And I'm going to skip through because she explained that brilliantly. And I'm going to go to this and summarize it. In the Gemini, which is against, for relapsing and remitting MS and against teriflunomide, we see that the impact of tolebrutinib versus teriflunomide on 6-month confirmed disability worsening was more evident in patients that had the pearls at baseline. So she alluded to that very brilliantly in her conversations with you guys. And so that just highlights that a little bit more in detail. And we see the same thing with Hercules, which was, remember, which is non-active secondary progressive MS. So we see the impact of tolebrutinib versus placebo in the 6-month confirmed disability progression was more evident in participants, again, pearls at baseline. So we're evolving our understanding of these MRI techniques and biomarkers in that respect. And then we see some phase 2 randomized control trials going on in FENopta, okay, which is fenebrutinib against placebo. And we can see some primary endpoints. The far left slide summarizes the right side of this, and you can see a reduction in terms of the number of T1 GAD lesions. And you can see here the efficacy at 48 weeks of the open label extension. So we're now looking at the open label extension, and you can see that for this, that 97% of participants remained in the open label extension, which is pretty high number from a tolerability. If you're having 97% in the open label, that's excellent. And 96 of your participants were relapse-free during the open label extension, and the median change from EDSS at each arm was still 0. So this is pretty exciting in that regard. Oops, I went the wrong way. Okay, and then we have fenebrutinib reduced new T1 lesions, and you can see that in the open label extension up to 48 weeks, a significant reduction in that respect. AEs, on average, open label extension, we're not seeing anything glaring, jumping out at us. Most of the AEs that we're seeing, if there's any, there's 1 grade 3 liver, which we're very, very well aware of, and that patient was asymptomatic. So this slide is kind of things on the horizon. They put this in here, so I had trouble saying everything. The videofludimus, calcium, glutamine acetate depot, frexalimab, CAR-T therapy, which Dr. Riley is about to come to give maybe a quick version of, hematopoietic stem cells, and remyelinating agents.
Thanks so much to Lisa and Dr. Newsom. We're going to move on right now with Dr. Claire Riley, who's going to talk about the evolving role of CAR-T therapeutics in the management of multiple sclerosis. Dr. Riley is the Karen Miller Associate Professor of Neurology at CUMC, Columbia Multiple Sclerosis Center in the Department of Neurology. Dr. Riley, thank you.
Thank you so much. And just one word about June. I think we all really try to live in her image. And I'm really happy to be here talking to APPs who are a tremendously impactful part of my own practice, my own education, and fulfilling my mission. So I'm going to talk to you about something that's different, maybe not so familiar. We're also relatively unencumbered by data, at least in multiple sclerosis, but I think it's an exciting potential frontier. So I want to talk first about a different way about thinking about inflammation. This is a schematic from the Lancet review that Jörg Schett authored in 2023. And so we'll start with tissue damage. Could be from a viral insult, physical insult. That stimulates an effector cell activation. These are innate immune cells, neutrophils and monocytes. And these effector cell activation pathway can go in one of two different ways. One is limited disease, inflammation, resolution, and repair. But there's another pathway, right? This is the autoimmune enhancer loop. And an individual who might be genetically predisposed, maybe also has environmental triggers, may enter this autoimmune enhancer loop where dendritic cells then go on to present autoantigen, stimulate autoreactive T cell activation. That in turn stimulates autoreactive B cells. Those autoreactive B cells evolve into plasmablasts, then plasma cells start secreting autoantibodies, and on it goes. Those autoantibodies then activate effector cells. And so this is the autoimmune loop of sustained inflammation. And our traditional approach across autoimmune disease has been continuous immunosuppression or immunomodulation. We heard beautiful and lengthy descriptions of those, but really important work that we've done. The question that I want to ask right now is, do we have a way to reset the immune system rather than suppress it in perpetuity? That's the question. I don't know the answer yet, but let's explore it together. This is the evolving therapeutic landscape of multiple sclerosis. You have heard about it. The only thing I want to say about this is that we still have an unmet need in MS care. We have made so much progress, but we're still not there yet. And everybody in this room and out there in the ether knows, as clinicians caring for MS patients, we haven't solved it yet. B-cell depleting therapy certainly has been tremendously impactful, but we all know that not every patient can tolerate B-cell depletion forever. And we don't get at PIRA, right? We don't really get at progression independent of relapse activity adequately. And as patients age, as we all age, we see this predominantly degenerative phenotype, often associated with inexorable progression. I'm going to skip this in the interest of time, but just kind of hammering the point of PIRA. Again, we think about MS as this T-cell mediated disease. B cells play such an important role. And we've seen across other neuroimmunologic diseases, B-cell depleting therapy also become an important strategy. And yet, there are potential problems. Dr. Newsom addressed these as well, but in addition to decreased vaccine efficacy, we see more infections with higher cumulative dose of anti-CD20, as well as hypogammaglobulinemia and secondary inflammatory conditions. So we know that this is not a forever path. So I want to suggest that potentially chimeric antigen receptor T-cell therapy may offer some of the benefits that we've seen with B-cell depleting therapy without the chronic exposure, without the chronic risk. At the top of the slide here is a CAR T-cell. It's composed of an antigen recognition domain, a hinge or a spacer, a transmembrane domain, a co-stimulatory domain, and an intracellular signaling domain. This is what manufacturing looks like. A very well-informed and consented patient goes in for leukapheresis as an outpatient. Cells are gathered. They're shipped off to a specialized manufacturing facility. They're genetically modified, most commonly using viral vectors, but other techniques are in development. A CAR construct, a chimeric antigen receptor, is inserted, and those cells are then expanded ex vivo over days to a couple of weeks with intensive quality control testing. Those cells are then cryopreserved, go back to the treatment center, and the patient receives typically lymphodepleting therapy with fludarabine and cyclophosphamide prior to infusion of that living drug. What are the advantages here over monoclonal antibodies? This is a living drug. This is not a static agent. And so those CAR T cells can expand in that human, reacting to how much antigen is present. And so it really takes some of that dosing question out, because the expansion of the cells to some degree is auto-regulated by the situation actually inside that patient. Tissues are penetrated by these cells. CAR T cells can cross the blood-brain barrier, and they can penetrate deeply into lymphoid organs. There's also a potential for some long-term surveillance and immunologic memory. This is a one-time treatment versus chronic dosing with biologics. There are lots of potential problems, manufacturing challenges, expense. The cost is about $500,000 at this time, but a key concept here and a focal point for why this is worth investigating is that this is a potential one treatment with a long-term benefit with significant upfront complexity and cost. So this is where we stand. The rationale I think I've already laid out, and I want to move quickly here, but we know that this immune dysregulation is at the core, that we've seen all these advances, but there are limitations still, and that penetration into the central nervous system, everything we've heard about. Let's think about pearls. Where are they? They're in the brain. Are monoclonal antibodies getting in there? They are not. So certainly small molecules and drugs like the BTK inhibitors may address these in different ways, but this is a potentially penetrant variant of a drug that we've seen be very effective. And again, this idea of immune reset, can we do it? The first patient was reported in August 2021 with systemic lupus erythematosus. So the first patient with autoimmune disease treated with CAR T, she was 20, she had very severe lupus. She'd been treated with everything, including belimumab, a proteasome inhibitor. She then got Cy/Flu, lymphodepleting therapy, and 1 million CAR T cells, CD19 CAR T. And very importantly here, she had significant expansion of the CAR T cells. In the days and weeks after the CAR T, you see her biomarkers normalize. Her double-stranded DNA resolves, her complements return to a normal range. She has a resolution of proteinuria, and the color blocks here, is this my pointer? You can see the color blocks, if I could even point at it. These are all her symptoms and her biomarkers, and they're all resolving. It's really very exciting. And importantly, she came off all of her immunotherapies. A year later, the same group, the Schett group in Germany, reported 5 lupus patients, had similar dramatic, sustained remissions. And these are further outcomes with these patients. So really tremendous improvement in all the biomarkers of lupus, as well as the composite measures of clinical disease. And this expanding experience here, including 15 patients across lupus, idiopathic inflammatory myositis, and systemic sclerosis, all had remission in the lupus patients, major clinical response, major reduction, with discontinuation of all immunosuppressive therapies. So what's happened in neurology? I think we're all impressed with the autoimmune data in general and rheumatology. We're bringing this conceptual framework into neurology. So I want to cut to the chase, but essentially we've seen a smattering of explorations in phase 1. Studies are starting up, including in myasthenia. In MS, we've seen 2 patients that have been reported in papers so far, and as well in MOGAD. So in the myasthenia patient, this is just so dramatic. This is a 33-year-old with severe refractory myasthenia, 10 years treated with all these things. All these little lightning bolts here in the schematic, those are hospitalizations with intubations for myasthenic crisis, okay? So think about this woman's life. Think about how hard she was trying to die, right? This disease was really incredibly grave. She received lymphodepleting chemotherapy, 1 × 10⁸ CD19 CAR T. She tolerated it well without any cytokine release syndrome or immune effector cell associated neurologic syndrome. She had a grade 1 transaminitis and a marked clinical improvement. And this is her like beginning to walk again. You know, this is kind of like, this is the reason we went into medicine, right? It's really to help people, and it was really quite impressive. This is not CD19, but B-cell maturation antigen-directed CAR T-cell. So BCMA is present on the surface of plasma cells, but not on more naive B cells. So in a truly antibody-mediated disease, BCMA has some appeal. And so this is a report of 12 patients treated with, who had NMOSD, who were treated with BCMA CAR T. And we see here that all but 1 had significant reduction in their aquaporin 4 antibodies. And the other thing I find quite surprising and interesting was that there was a reduction in EDSS score in these patients over the course of their follow-up, which was a median of 5.5 months. So very intriguing. This is another, just again, very small amount of data I'm showing you here, but a patient with stiff person who had been treated again with everything and the kitchen sink, who then went on to get CAR T. This is CD19 CAR T after standard lymphodepleting chemotherapy, and had a marked response, including a drifting down of the GAD antibody. But when you look at her, particularly her ability to walk, you know, this is her duration of ambulation. And we have relatively short follow-up on these individuals, so hard to know yet how durable these responses will be, but you can't argue that they're not impressive. An individual with MOG antibody disease, I'm going to skip over for the sake of time, but it is also interesting. And I want to just pause here. So the reconstituted B cells, when they return, they're phenotypically different. It does support this immune reset hypothesis. I can't talk about it right now, but these cells really are different. There was initially concern that CD19 CAR T might actually worsen EAE, MOG-induced EAE. This is Scott Zambel's work from UCSF. In fact, these mice did well with CD19 CAR T. And in CD19 CAR T treated animals, as opposed to cyclophosphamide plus a non-CAR T cell, in the CD19 CAR T treated animals, there was no inflammatory pathology 28 days after CAR T. And this is just a slide showing that CD19 CAR T penetrates deeply into lymph nodes. So this is CD19 and CD20 staining before and after CAR T as opposed to after anti-CD20. And you can see that there's really a marked difference in penetration by these therapies. So here we have the 2 MS patients that have been published on, and although we've seen some conference proceedings about other patients, so these were 2 patients with progressive multiple sclerosis treated with CD19 CAR T. Importantly, each of these patients had failed maximal therapy, including anti-CD20 therapy. We saw that in these patients, the cells expanded, they crossed the blood-brain barrier, they're present in the CSF, and there was a reduction in CSF markers of inflammation. Particularly in these patients, they remained clinically stable, but there was no reduction there was no increase in CSF inflammation. Because some have worried, okay, you have this inflammatory process. How do you know that, CD19 CAR T might not make things worse? So thus far, very interestingly, the number of oligoclonal bands were reduced, and that these patients did have a difference in the amount of expansion that they experienced, and that may be informative in terms of the timing of treatment, but also that kind of autoregulation that the cells kind of expand due to the amount of antigen that's present. So, 601. There's a lot to do. CAR T therapeutics really began in oncology. I left out that whole story, just assuming you're ready for it. Okay, they came from treatment of lymphoma, where we know B cells are behaving badly. And they've thus far made a really interesting stamp, I think, in autoimmune disease. They've caused me to think about some of the mechanistic underpinnings of multiple sclerosis in a new way. They might offer a deeper immune reset. There's clearly something different going on than strictly constitutive dosing of anti-CD20. And as I've seen, and Dr. Newsom made the comment as well, like when you see your own patient have this kind of complication with other therapies, you take it hard. Now I've seen patients have serious complications with CAR T therapy as well. But I think that when you think about the duration of exposure and the lifetime of having MS, there's something very appealing about exploring thoroughly a technology that's been such a revolutionary treatment in oncology. I would argue now is taking a commanding stance as being a revolutionary treatment in rheumatology, and we'll have to see where we go with it here in MS. There are many other potential applications, antibody-mediated diseases, some of which we care for, and in diseases in which, like MS, where B cells play such a key role in the inflammatory cascade. So safety is the first priority of phase 1 studies. These are underway. There are lots of interesting considerations about allogeneic versus autologous CAR T cell products. There's scalability issues, there's access issues. I would encourage you to come to the DMT session on Thursday afternoon, where I'll be presenting the experience of the first 8 patients in the BMS CAR T study with multiple sclerosis. Thank you.
Thank you so much, Dr. Rowley, for that quite comprehensive overview. At this point, we're going to use another 5 minutes for Dr. Newsom to summarize some of the information about disease-modifying therapies, not only what's available, but what's in the future as we conclude the program. Thank you.
So you thought you were getting rid of me. I'm back. This is one slide, the only slide I'm putting up there. I think this is probably, at least in my view, one of the most important slides, where when you have the person sitting in front of you and you're trying to make those hard decisions, whether it's the treatment-naive patient, the switcher, the discontinuer, right? Because there are studies now thinking about, do we discontinue therapy after a certain age because of the risk of some of our therapeutics? I would encourage you to think about these different features, considerations, factors, whatever you want to call, and these buckets. Obviously, you heard, I think earlier, the patient-related factors. You heard Dr. Morrow say, well, if someone comes into the clinic and they have spinal cord lesions, spinal cord onset MS, that makes me extremely nervous. It's probably someone you wouldn't hold back therapy, right? Risk tolerance, the story I was going to mention is I early on made the mistake of thinking a person would walk out the doors with the therapy that they were vetted on getting and wanting to do, and not reading the cues in the room that they were not comfortable with that decision we discussed. And they came back 3-6 months later. I was like, oh, how are things going? Oh, they never started the medication. Okay, great. Well, why? I didn't feel comfortable. So work with your patient, shared decision-making, very important. Comorbidities, I think as our patients age, and you heard about this earlier, they start to have other comorbidities that influence, their disability, and not just MS-related. Reproductive status, of course. And then disease-related factors, I mean, it can go on and on. This could be a whole entire session of itself, but vaccine status is quite important. I think the risk of not treating or undertreating the disease, in my view, is probably one of the most important characteristics. Depending on where you are within the world, there could be barriers that are out of our control, whether it's insurance-based, access to services. I think with CAR T, we'll have to see. We're all very excited about this. There may be some barriers to access, so we'll have to see where that goes. And I will just say I lied. This is the last slide. This was a nice paper that was published, I think, a little over a year ago. In my view, when you try to think about, flow charts, what are you going to do? This is a nice, I think, pretty simplistic flow chart. Now it's broken into 2 treatment strategies, right? We could almost think about with our therapies and efficacy data almost in 4 different buckets. But I think this is at least a decent way to think about it. And I'm not going to belabor the point, but hopefully all of you got something from any of the lectures we did. I know we took you through a whirlwind from diagnosis to what's happening real world, clinical trial-wise, some emerging, exciting data from CAR T, as Dr. Riley went through eloquently, by the way. You saved us. You're their cleanup act, actually. And we're happy to stay, to answer other questions. Thank you.
I'd like to thank all of our faculty, Dr. Merle, Dr. O, Dr. Riley, Dr. Newsom, and Lisa, for absolutely amazing presentations, trying to give us APPs as much information as they could cram into these 2 hours. And I, at least as a practicing APP, certainly appreciate it. I'd also like to thank academic CME for all of their efforts in putting the program together. Certainly to BMS as our sponsor for this program, for their commitment to advanced practice providers. And to echo one of the things that Dr. Riley said, I would encourage you, if you have the opportunity, to attend the platform sessions on disease-modifying therapies. I think they're Thursday afternoon. There's 4 simultaneous platforms, but there's a lot of really good and cutting-edge information that's going to be presented specifically in the disease-modifying therapy platforms. And also new this year, we have added a platform session for late-breaking information, and that's going to be at the ungodly hour of 7 a.m. on Friday morning. So if late-breaking news doesn't wake you up, I don't know what will. So I would encourage you to please enjoy your time at the CMSC. Please complete your evaluation forms, and thanks again for joining us this evening.
Can you hear me? As you're walking out, if you're interested in your certificate for CE CME, you can go to the QR code and accept it there. Thank you.